Welcome to Neuroimmunology Demystified, a critical resource for every physician. In today's session, we're diving deep into autoimmune disorders that impact the nervous system. Our goal is to equip you with the knowledge to recognize, diagnose, and manage these complex conditions effectively, ultimately improving patient outcomes. Neuroimmunology is a rapidly evolving field at the intersection of neurology and immunology. Understanding it is crucial, because autoimmune neurological disorders are often misdiagnosed or delayed in diagnosis, leading to significant patient morbidity. This video is designed to provide you with a practical overview of key conditions, essential for general practitioners, neurologists, and specialists alike. Let's start with multiple sclerosis, or MS, a chronic inflammatory demyelinating disease of the central nervous system. It's one of the most common autoimmune neurological disorders you'll encounter, and early recognition is key to preventing disability. MS presents with a wide range of symptoms, often fluctuating and unpredictable. These can include visual disturbances like optic neuritis, numbness or tingling, muscle weakness, fatigue, balance problems, and cognitive difficulties. The insidious onset can make diagnoses challenging. Diagnosis typically involves MRI of the brain and spinal cord, looking for characteristic lesions, along with cerebrospinal fluid analysis and evoked potentials. Management focuses on disease-modifying therapies to reduce relapse rates and slow disease progression, alongside symptomatic treatment and rehabilitation. Next, we have myasthenia gravis, or MG, a chronic autoimmune neuromuscular disease characterized by fluctuating muscle weakness and fatigue. It's caused by antibodies that block or destroy receptors at the neuromuscular junction, preventing nerve impulses from triggering muscle contraction. Understanding the pathophysiology of MG is crucial. The autoimmune attack primarily targets acetylcholine receptors, leading to impaired communication between nerves and muscles. This results in the hallmark symptom of fluctuating muscle weakness, which worsens with activity and improves with rest. Clinically, MG often presents with ocular symptoms like ptosis and double vision, followed by bulbar symptoms affecting speech and swallowing and limb weakness. Diagnosis involves antibody testing, electrophysiological studies, and response to cholinesterase inhibitors. Treatment includes symptomatic relief, immunosuppression, and sometimes thymectomy. Autoimmune encephalitis, or AE, is a group of severe inflammatory disorders of the brain caused by antibodies targeting neuronal cell surface or intracellular antigens. These conditions are increasingly recognized as treatable causes of acute or subacute encephalopathy. AE presents with a diverse range of psychiatric, neurological, and cognitive symptoms, often mimicking other conditions. Common types include anti-NMDA receptor encephalitis, which can cause psychosis, seizures, and dyskinesias, and LGI1 encephalitis, often associated with faciobrachial dystonic seizures. Early and aggressive immunotherapy is critical for AE. First-line treatments typically involve steroids, intravenous immunoglobulin, or plasma exchange. For refractory cases, second-line agents like rituximab or cyclophosphamide may be used. Prompt treatment can lead to significant neurological recovery. Finally, let's discuss neuromyelitis optica spectrum disorder, or NMOSD. Once considered a subtype of MS, NMOSD is now recognized as a distinct autoimmune condition, primarily affecting the optic nerves and spinal cord, often more severely than MS. Differentiating NMOSD from MS is crucial due to different prognoses and treatment approaches. NMOSD typically involves severe recurrent attacks of optic neuritis, often bilateral, and longitudinally extensive transverse myelitis. The presence of aquaporin-4 antibodies is a key diagnostic marker, distinguishing it from MS. Diagnostic criteria for NMOSD rely on clinical presentation, MRI findings, and the presence of AQP4 IgG antibodies. Management focuses on acute relapse treatment with high-dose steroids or plasma exchange, and long-term prevention with immunosuppressants to reduce attack frequency and prevent disability. In conclusion, early recognition and appropriate management of these autoimmune neurological disorders are paramount. As physicians, your awareness of these conditions can significantly impact patient outcomes. Remember, collaboration with neurologists and specialists is often key to providing comprehensive care. Thank you for joining Neuroimmunology Demystified.